Houston shortly, but just want to thank you again for taking the time out of your busy schedules to be with us. As you can imagine, this is our continuation of our Learning for Life webinar series. I am having the privilege again of serving as your host and welcoming you to our Integrated Care in Sickle Cell Disease Primary, Secondary, and Tertiary Care webinar event. My name is Delaney Hines. My pronouns are he, him, and I have the luxury of serving as the chair for our education committee at the Sickle Cell Awareness Group of Ontario, and also serve as a member of the board of directors and have been the chair for the planning committee for the Sickle Cell Disease Summit for the last 3 years, and looking forward to another offering this August. If you or members of your network would like to refer to the information shared in this session, a recording of today's session will be posted on our website at sicklecellanemia.ca for viewing at your convenience. One of our missions at the SCAGO is to serve as a conduit for members of our community to access evidence-based, up-to-date information like we have prepared for you this morning. Today's session is important because integrated care in sickle cell disease is an approach where primary, secondary, and tertiary care providers work together to support people living with sickle cell disease throughout their lives. It focuses on ensuring patients receive the right care at the right time, whether that is routine monitoring in primary care, specialized treatment at tertiary centers, or urgent management in emergency settings. So we hope today to impart how coordinating care across healthcare settings, integrated care, helps improve prevention, manage chronic complications, and respond effectively during acute episodes. This approach supports better communication between healthcare teams, it reduces gaps in care, and ultimately improves health outcomes and patient experiences for individuals living with sickle cell disease. So as I mentioned before, we'll be hearing from three of our guests who I'll introduce shortly. But before getting to that, I want to make sure I spend some time just sharing a bit of housekeeping and our light acknowledgement. Uh, um, like I mentioned, this session will be recorded. Following the light acknowledgement, we'll have the intros to our speakers, and then we'll have the formal presentations from our three speakers, and then a Q&A. We ask that you save your questions, thoughts, or concerns until the latter portion of our session, where our guests will be able to answer questions individually. Also, you can also submit your questions throughout the presentation by way of the chat feature or the Q&A feature. You'll have noticed by now that your microphones have been disabled, and that I can, have folks unmuted during the designated Q&A portion of the conversation. But in the interim, please do feel free to use a Q&A, as I mentioned before. Closed captioning is provided as well. If you click on the More button within your toolbar, you'll be able to see an option for you to leverage the closed captioning. Please use respectful language in the chat. As you can imagine, we want to try to keep this as appropriate as possible and on topic. Please do not post other material unrelated to today's discussion topic as well. And as you can, please keep discussions and comments on topic as much as possible. That'd be greatly appreciated. Ginkgo does reserve the right to pause a session or seek to remove any participant who does not abide by these rules. But thank you for your understanding and agreement to a positive participation. Last disclaimer before jumping into our line acknowledgement. I just want folks to remember that the information shared today does not constitute medical advice and is shared with you for information purposes only. No materials shared with you are intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking any new healthcare regimen. So please do not disregard professional medical advice or delay seeking it because of something said during this webinar. Formally, I'd like to acknowledge the land I'm joining from you all today. I'm currently in Ajax, Ontario, in the traditional territory of the Huron-Wendat, Haudenosaunee, Anishinaabe, Mississauga, adjacent to the Mississaugas of Squamish Island First Nation, all in the treaty covered by the Williams Treaty. I'm going to pull up the land acknowledgement for Toronto, but I'm delivering my own personal one. I come to this country as a son to two Jamaican immigrant parents who came to Canada for greener pastures and an opportunity to live, play, and and work freely and provide a better opportunity for me and my brothers. So I definitely take it upon myself to be thankful and acknowledge the privilege I have to be able to, operate in the spaces that I've been able to operate in and also be able to participate in events like this one with all of you lovely folks. So it's really important that we all take a second to acknowledge the opportunity we've been presented by being able to, call this country home. So now that we've gotten through all the housekeeping, without further ado, I'd like to introduce our first speaker, Dr. Jacob Pendergrast. He is the current Associate Medical Director of Blood Transfusion Service at the University Health Network. He's a clinical hematologist at UHN and medical director. He's treated patients with hemoglobinopathies at Toronto General Hospital since 2004 and is an associate professor at the University of Toronto. His research focuses on quality, utilization, education, and safety in transfusion practice. Following Dr. Pendergrass, we have joining us Dr. Ola Adisafe. He is a family physician with broad clinical experience and a strong focus on patient-centered care. He brings expertise in preventive care, chronic disease management, and continuity of care for individuals living with sickle cell disease. And last but certainly not least, we have my friend Dr. Marco Eric. Well, they're all my friends, but Dr. Eric and I have a much more close connection. He is an emergency physician and medical educator at Humber River Health and the University of Toronto. He leads continuing medical education and simulation training initiatives and is actively involved in quality improvement and emergency care innovation. So I'm going to stop sharing my screen now. And Dr. Pendergrass, the floor is yours.
Okay, thank you so much.
No problem.
And I will just get my screen set up here. Okay, and is that showing proper?
Perfect. Yep, you're good to go.
Okay. Um, so yeah, I think to speak about the role of specialized and tertiary care centers, I think we have to sort of pan back and look at the overall demographics of sickle cell disease and the way in which care has evolved over the course of my lifetime, really. And when you look at, I was born in 1971. At that point, the life expectancy of sickle cell disease in North America was around, 17, 18 years old. It was really considered to be primarily a pediatric condition. There were very few adult clinics because there weren't that many adults, and we're actually still catching up in providing adequate care for our large and growing population of adult patients with sickle cell disease. But certainly, the prognosis has dramatically changed, so depending on, which data source you're looking at, we have data from the United States suggesting that median life expectancy is 60 years. In Ontario, the average life expectancy is about 55 years. There's been, enormous improvement. A lot of this came, with just having the medical system formally acknowledge the existence of this disease and begin creating resources to treat it. But there were also very important landmark medical innovations. The role of preventative penicillin before the age of 5, dramatic improvement in life expectancy due to prevention of overwhelming sepsis. Hydroxyurea, which is still our first and best therapy for sickle cell disease, became licensed for use in the United States in the 1990s. And with the growing recognition of how important transfusion is for the prevention of stroke, which then opened the door for the judicious use of transfusion in other settings as well, we've had further improvements in life expectancy. And if you look now at sort of what the mortality rate is for sickle cell disease around the world, you can see that, having an adequately resourced and funded medical system makes a big difference. In parts of the world where sickle cell disease is very prevalent, which are more resource constrained in terms of how much money is available to the healthcare system, life expectancy is still poor. And in fact, in some parts of the world, it's been estimated that the great majority of children born with sickle cell disease still don't make it past the age of 5. But as we have a shift in demographics towards countries that have more money to spend on this, it doesn't take a lot of expenditure to have dramatic improvements in life expectancy. And I think this is really encouraging news, that we are seeing that that this could become a, what was thought to be a tragic childhood diagnosis marked by terrible suffering and premature death is now a manageable condition that you can expect a near normal life expectancy. And in fact, that's what we are aspiring to in the care we provide our patients is normal lifespan and minimal symptoms to the best we can achieve that. A model of care that mimics patients who are living with cystic fibrosis or hemophilia or diabetes. If you are on top of this condition, if you're managing it well, things can go well for you. We're not certainly the best in the world in terms of our life expectancy, but we're getting there in North America. In terms of what this has meant in Ontario, you can see that the traditional sort of pyramid shaped life distribution of populations in areas where there is high childhood mortality has shifted. We now are seeing a larger and larger proportion of patients making it into middle age, making it into their elderly years. I have patients who are approaching 80 with me, and they continue to say to me, like, I cannot believe I'm still alive. And I say to them, and there's nothing wrong with you. You're still in good health. Believe it. This is what you can achieve if you just stay on top of this condition your whole life. It is still largely a young population in Ontario. And we continue to have newborns born in Ontario with sickle cell disease, probably about 40 babies, 40 to 50 babies per year are born with sickle cell disease in Ontario. But we're catching them early with newborn screening, getting involved right from the beginning in terms of providing sort of basic, rudimentary care, and we are seeing improvements as a result. In terms of where patients are located, we have studied this, and most of them are still in the large urban areas, particularly in the Golden Horseshoe, some in Ottawa. There's a population of note in sort of the London, Windsor area as well, but really all through Ontario. I have patients who I manage in Thunder Bay, and even further west than that. And this is a model of care that we are able to extend, and which the province is now formalizing into a system of referral centers where you have primary care for sickle cell disease provided everywhere, and then you have your regional referral center, and then your more specialized tertiary care, which typically are sort of in the areas where there are the most patients, so typically the GTA in Ottawa, and I think as the figures show here, not every patient is going to need the highly intensive care. We do know that there are many patients who have relatively infrequent need for hospitalization, for example, and then we have patients who are very frequently in hospital or seeking emergency care. And so there's a spectrum of need. And that need does not necessarily localize to where the tertiary care centers are. We can have extremely sick patients in very remote areas, but through virtual care, through networks of care that where we are partnering with our local care providers, I think that we are able to reach those patients too and ensure that they get the care that they need. Now, that being said, if you look at the overall change in life expectancy from the 1970s up until current day, you can see that in fact most of the benefit has been with children. That the mortality rate and has gone down and the life expectancy has gone up most dramatically for children under the age of 10. And in terms of what the life expectancy is in adults, we have not made as much progress. I think that is a sobering realization. That there has been some benefit. You can see that the shift of the curve. That going from that red curve up to the purple curve is there's been a little bit of an improvement, but we haven't had the same dramatic gains. And and I think, some of this can be attributed to the fact that we just do not have enough comprehensive care centers for adults. And so when children age out of pediatric systems, which are much more established, have years and years of experience, and they go into the adult care world, there's not always a comprehensive care center waiting for them. Or even if there is, sometimes we just lose those patients. They are 18, they are no longer under the control of their parents, they can make their own decisions. And a lot of them want nothing to do with the medical system anymore. They're done. They want to live their lives and not think of themselves as a sick person or someone who needs medical care all the time, and they disengage from the medical system. But for whatever reason, we do see that after that transition point from children to adults, the number of complications steadily increases, and they're not all the same types of complications. I think if you look individually at the types of morbidity that children develop versus adults, there is definitely a difference. And um, in terms of the of when the medical costs peak for patients with sickle cell disease, you can see it's really in the sort of the 20s, and that's often when we find that patients' disease is the least under control, and they're in hospital very often, being hospitalized frequently. It's not pleasant for them. It's expensive care as well, and certainly the cost tends to go down as we sort of get better control of disease. As patients tend to reconnect with the medical system, and get more on top of their illness. Typically we sort of see this sort of more sort of in the 30s or so. But there's no question is that the actual disease itself has changed. And if you look at the main causes of death in sickle cell disease for patients under the age of 20, you can see, it's things like infection, like sepsis. It's sequestration crises, typically involving the spleen. These are major drivers of mortality. But, in adults, it's more sort of the chronic, irreversible organ damage, that kind of just picks away, the steady decrease in lung function and kidney function, uh, liver disease, that sort of thing. And this is where we are finding that we really need to be on top of the long-term chronic management of these patients. A sequestration crisis in childhood is an acute emergency. You can come in, and if you deal with it properly, you can save that patient quickly. And we've made huge gains in educating parents on how to recognize the sequestration crisis, educating doctors on how to treat it properly. Infection, just prophylactic penicillin before the age of 5, and being on top of vaccinations afterwards, does a lot to prevent that. But to really, prevent the slow deterioration of lung, kidney, and liver function, you really do need long-term, comprehensive, preventative health maintenance, not just dealing with emergencies, not just putting out fires, but managing, on a regular basis, early signs of disease and getting on top of them before it starts to result in actual organ dysfunction. So, it's another way of sort of showing, the effects of the chronic illness that sickle cell patients live with. The quality of life of having sickle cell disease is somewhere between being on chemotherapy for cancer, and maybe having cystic fibrosis. It is a definitely a burden for these patients. So even if they are not in the hospital frequently having pain crises, just living with sort of this chronic condition is difficult, is challenging. and is, the kind of thing where, you do need to have a multimodal approach. Again, it's not just the medical model, it's not just doctors and prescriptions. There has to be really good nursing care, there has to be really good social care, social work support, psychological support, paramedical, support through things like physiotherapy, that sort of thing. All of this is really important to maintain that quality of life, even as we are extending lifespan. So, what is the current model of, preventative healthcare that we should be aspiring to? So patients, everyone's different, but I would say that, a patient with sickle cell disease needs to have a doctor's appointment typically 2 to 4 times per year, and that doesn't have to be necessarily a doctor. That could be with a nurse practitioner. That could be with, a family physician who has good, care about, enough knowledge about managing sickle cell disease. And for sure, there are some patients who are super, super stable, like truly have no symptoms at all. And I'd say once a year checking is probably fine. And we have other patients, I have them every 2 weeks. We have to check in to keep those patients stabilized. But on average, I say 2 to 4 times per year. And in terms of the type of care that needs to be available to these patients, you do need to have adequate technology to detect early signs of that chronic organ dysfunction. So transcranial Dopplers for, risk stratification for stroke in children. And although it may look like that there's good evidence for this in adults as well, although in adults we tend to rely more on MRI scans, keeping on top of ophthalmology to assess for sickle retinopathy, echocardiography to assess for pulmonary hypertension, the ability to do a sleep study to detect nocturnal hypoxemia, which can drive sickle cell disease, abdominal imaging to see signs of early medical renal disease or liver disease, bone density, so you can pick up osteoporosis before those compression fractures can develop, which can cause tremendous discomfort. The ability to obtain hip and shoulder imaging, X-ray at a minimum, MRI ideally to pick up avascular necrosis, fertility support, becoming pregnant for people who are seeking to have children, and then avoiding complications during the pregnancy for women. That's a really important resource. And you have to have adequate lab testing. This is something I am known to nag my patients about all the time, but it's like you do need to get your blood work checked regularly, whether you are on treatment like hydroxyurea or not. This is how we can pick up not only side effects from the medications you're being prescribed, but also, signs of injury from the sickle cell disease itself. One of the very first signs that the kidneys are being injured is we start to see protein in the urine, totally asymptomatic. But it's a warning sign, and as soon as we see that, we get on top of it. You do not want to wait until your patient is actually starting to develop kidney failure, let alone to the point where they're waiting for a transplant. So, the overall model of comprehensive care that patients require is every single sickle cell patient needs to have access to some degree with a physician who is a specialist in sickle cell disease. They don't need to see that person every single visit, but that person needs to be available. There needs to be a medical home where there is a hematologist who has expertise in sickle cell disease available to deal with the more complex questions. Typically, where that specialist is also where you would have a lot of the other support workers, social work, nursing, therapeutic apheresis for transfusion support and that sort of thing. And then, as well, ideally there would be an infusion center or a day hospital so that you don't, lean too heavily on the emergency room for care. Ideally there should be a transition navigator to get the patient from the pediatric onto the adult model of care without losing them. And then, all the other things that, come up, that we need to have available to us. Patients sometimes need dental work. That's more complicated in sickle cell disease. Some patients need physical therapy. As they get older, they need occupational therapy. All of these things are sort of part of the overall model. Do these things all have to be offered in the same place, like in the same hospital? I think that makes it simpler for everybody if that's possible. But for patients who are living very far away from a large comprehensive care center, some of these things can be provided locally, and some of them can be provided sort of as needed, for during an occasional visit to a large hospital. And how often that needs to occur depends upon how complicated the patient's care is. So I might have a patient up in Northern Ontario who can be managed most of the time with a family doctor or a general internist. But when she is seeking a pregnancy, I say you need to be in a specialized care center for that. And so that might be the time that get on a plane and come down to a high risk obstetrics program as one such example. Um, this is a model which has been shown to make life much better for the patients. They don't get hospitalized as often when they have comprehensive care. When they are hospitalized, they don't stay in hospital as long as they otherwise would. This has been found in other centers to decrease the need for emergency room visits. Um, you know, it certainly saves money. There's no question, that in terms of for governments, this is a much more economically efficient way to provide care. But it's also just humane, just to have patients not bouncing in and out of hospital all the time, but just sort of having that regular access to all of those modalities of comprehensive preventative care. Okay, I will stop there and give my other co-presenters time for their presentations, and then I'm happy to take part of whatever discussion people would like to have.
Fantastic, Dr. Pendergrass. I mean, I have a ton of questions, but I'll reserve them for later on because you presented some really compelling not only factoids but some areas of potential opportunity. So with that, thank you, Dr. Pendergrass, for that fulsome orientation to kind of the models and the different ways in which we're seeing folks require models of care that can help them along their patient journey. Next, we have joining us is Dr. Ajisafe, whose presentation is going to help us better understand the role of primary care in routine monitoring, prevention, and chronic disease management. So, Dr. Ajisafe, over to you.
Thank you.
No problem.
Share screen. Can you see the screen?
Yes, it's currently in editing mode. If you wanted to put it in presentation mode, that would make it bigger.
How do I do that?
At the very top, you'll see, where it says the file, home, insert. If you go slide to your right, you'll see slideshow in the option features at the top of the screen in your window.
Stop. Shall
The same area where you'd
no.
usually click to save the file. You see where it says file, home, insert, draw, design, those features.
It's just showing. Okay, let's see. Oh no, I can't. You are sharing the screen. That layout. Guys, show more. No.
Oh,
You are
you can also
sharing.
create your function F5, but because right now you're
F5.
sharing your screen, but if you press function F5 on your keyboard, it should put the slideshow into presentation mode.
F5.
Only challenge is you'll have to have the PowerPoint selected as a window you're navigating. So because there's two options. On the PowerPoint, in PowerPoint, you'll see slideshow at the very top.
Okay. Share. No.
No, not share. That's going to share the file. If you click on slideshow, there we go. You're right there. You're right there. Right. Yeah, right below, you'll see slideshow underneath your cursor. Right there.
Oh, this one.
Perfect. And then you click
Okay.
from beginning. No, no, no. Far left from beginning.
Oh, okay.
Yes. Beautiful.
Oh, perfect. Okay.
There we go. Now we're good to go.
Okay. Good
Over to
morning,
you.
everybody. My name is Dr. Ajishap. I'm a primary care coordinator for Sickle Cell Black Pea Community Health Clinic. And I'm going to be sharing with you today the role of primary care in the management of sickle cell disease. The learning objective will be like understanding the role of primary care in sickle cell disease, then recognizing key preventive measures, identifying when to refer to specialist care, and support chronic pain and psychosocial needs. As just a brief overview of the sickle cell disease, we know now sickle cell disease is no, the red cells are sickled. That's just why the name sickle cell disease, and the normal cell is oval shaped. And because of this nature of the shape of the disease, I mean of the cells, they tend to clog. They clog together and they block blood vessels. And when they block blood vessels now, it impacts the flow of blood to the organ. And that is what causes the problem. There's decreased organ perfusion and decreased function of the organ. Even sometimes that could be death of the organ. And that is what manifests as complications or the presentation a patient with sickle cell comes to doctor for. So with that overview, primary care is at the center of the management of patients with sickle cell, from the patient to the family to the specialist, the doctor, the family care doctor is there. Primary care per se gives holistic care. Holistic care means that patient has is able, body, mind, life context, everything is put into consideration when you are seeing a patient. It's just not only the physical, you look at the spiritual and the mental and every aspect of the patient being. And that is what a care is supposed to be for any disease, including sickle cell. So when somebody comes with a sickle cell disease, the primary care is the hub where all the other specialties can be coordinated, all the other resources that are available can be put into place. So primary care actually, like I said, it's center core where patients need to see the doctor, and the doctor is integrated into all the aspects of care that is required for a comprehensive care for a patient with sickle cell. So at the primary care level, that means that, prevention, crisis triage, when there's a crisis or a patient comes in, how do you manage, the different levels of care that you give, and then the long-term monitoring of the condition. And so for the prevention, like Dr. Pendergast has actually alluded to, vaccination is important. And, patient needs to come to the doctor for pneumococcal vaccination, meningococcal influenza, hepatitis B. Those are the main things. But again, all of the routine vaccines are important. But these ones are specifically important for sickle cell disease, but because if a patient that has sickle cell has any of these diseases, it's more grave, it's more deadly, and that's why they need to be protected. And this is just vaccination that can be given to patients at the primary care level. And again, before the age of 5, children need to have prophylactic antibiotics. Penicillin is often prescribed for the patient so that they can at least be equipped whenever there is any crisis or there is infection going on in the patient. Because these people are very vulnerable, and you want to make sure that they are prevented from having infection most of the time. And again, as adults or even when they're going on routine screening of patients, the blood pressure, kidney function, the eye examination, all these things are important because the idea is to prevent complication. Hypertension is common in the sickle cell. Kidney function is common because of this, what I just said. There is a bit of malfunction of the red cells when the blood cells sickle in the kidney area. So you have to monitor and try to be proactive. Make sure that the patient's renal function is monitored at least annually so that you know whether there's any problem and when to intervene. Also, ocular problems very common in sickle cell. The sickle cell can block the blood vessels in the eye, and the patient can have issues with their eye. So it could be blind, anything could happen. It could have a retinal hemorrhage or anything. So the patient needs to have routine checkup too. These are all the things that the primary care can do. And again, like Dr. Pendergast has alluded to, annual transcranial Doppler is important in pediatrics. It's just to make sure that we are on top of it in case they are going to have stroke. Look at how the blood vessels are flowing in the brain and the patients, how they are coping. So those are the things that we have to do. And as part of this, apart from the prevention, there should be a routine screening, a routine appointment that the patient must have with the doctor. The doctor said, Dr. Pendergast, 2 to 4 times a year, to me, I think yes, it falls in that category of 3 to 6 months. That I think every patient should be seeing a doctor at least twice a year minimum, but every quarter, because it offers the doctor opportunity to assess. Like we're saying, prevention is better than cure. So when the patient comes in, you assess the pain threshold, how the patient is going, what medication the patient is taking for pain control. Is the patient free of crisis or not? You check the pulse oximeter to make sure that oxygen flow is good, and are the patient adhering to the prescribed medication? Maybe the patient is on adoxyurea, is on folic acid. Is this patient taking all this medication on time and as prescribed? All these things are important, and these are the things that the primary care doctor can do. Like I said, every 3 to 6 months, the patient needs to come to the doctor, and at the minimum, the CBC and the reticular side count needs to be done. This is just to make sure that at least the blood, the hemoglobin of the patient is known, and is there any crisis going on? Is the patient bone marrow producing enough? And all those things, those are important, and it needs to be checked like every 3 to 6 months. And every year, the patient needs to have the renal, liver function, and urinalysis. Again, prevention. You want to be sure that they don't have the kidney complication, renal complication. And these are the areas that, you can catch them early when you start to do the checkup. For pediatrics too, like I said, the annual TC for the stroke risk is important. This is a thing that can be done on when during the appointment time. Sorry. So, apart from the health maintenance and monitoring, early detection of complications is important. Patients could have complication any time, but the moment they see a doctor, they see their family care doctor who is knowledgeable in the care of sickle cell, they can be easily diagnosed and then treatment offered on time. Because like I said, prevention is always better than cure. So once you know what the patient is complaining of, and you go for treatment early, most of the time, the complication is not as magnified as it can be. And some of the complications that the patients usually have is the acute chest syndrome, which means that patients come in with chest pain and it's severe pain. Most of the time they think, oh, this patient is having a heart attack, is having pneumonia, or any of those complications. But any doctor that is knowledgeable in the care of a sickle cell disease patient will be able to understand this complication and treat accordingly. We've discussed about the splenic sequestration, when the kidney soaks up all the blood in the body. Again, early detection, when you examine the patient, is the spleen okay? Is the spleen enlarged? Once you see that, then you can know, oh, this sequestration is coming and it's an acute emergency. You have to refer to the specialist immediately for care. Again, stroke symptoms. There's a patient coming with pain, inability to move the hand or leg on one side, you did speech slurred or stuff like that. All those are complications and symptoms of stroke. And at primary care level, all these things can be diagnosed and appropriate treatment offered. Avascular necrosis. Patients come in sometimes, they cannot walk because the hips are a little bit painful. Is the blood supply to the hip compromised? That is what avascular necrosis does. Blood supply to the hips and all the bones are not adequate, and the patient comes with pain, and that could be death of the head of the bone, like especially in the hip area, that could be bone death, and this patient now, we may need hip replacement. So early diagnosis is very important to salvage the hip or to manage appropriately when the time comes. Again, infection, patients are prone to infection, that is why they needed what I said about the pneumonia and meningococcus, hepatitis B. All those infections and, infections that can be very, very deadly in sickle cell disease patients. So early identification of this infection is very important. Patient comes to you, oh, I have cough, I have chest pain, I have all these things to be able to adequately diagnose. You have access to urinalysis that you can use, whether it's infection of the urine or any infection or any part of the body. So early detection is a very key word in there. care of this patient in primary care. And then again, patients come in with acute issues in primary care. Not all cases require emergency care. Some of these cases can be managed at the primary care level. Like I said, it's prevention. So when you are doing the prevention, you are monitoring, it's very easy to assess, for the patient to be diagnosed properly and treated. Like, how do you monitor the vaso-occlusive complication of sickle cell? What do you tell the patient? How do you prevent this? Hydration is very important. Patient needs to drink more water so that they can dilute the blood. When they have pain, the pain should not get to the maximum threshold before they take pain medication. So they should be able to have access to NSAID and all the pain medication that have been proved to be helpful for them in the past. So all these things are education that the patient can be offered at the primary care level. Heat therapy, when the patient is having pain anywhere, how do you do with heat? How does heat help in the prevention of having complications? A patient comes in with fever. What is the cause of the fever? Early diagnosis, it can be done at the primary care level. And again, when you see the patient comes in, not only can you do treatment at home, you can do treatment in the emergency room too. The primary care doctor will be able to know when to refer to the emergency room for urgent treatment, or when the treatment can be managed at home. So these are all the responsibilities of the primary care doctor who is knowledgeable in the care of this patient. When you put all this together, you find out that the patient can easily be managed in the acute setting, in acute crisis, but in the primary care level, because you are cognizant of the fact that, all the resources available, one can tap into them, you can refer appropriately, and you can educate the patient about, the kind of food, what to drink, medications to take, and all these other things. In alignment with what even is applicable to in the secondary care setting, chronic disease management is part of what primary care doctors do. In Canada, most of the specialists prescribe the dosage, but education and monitoring of this medication is the responsibility of the primary care doctor. So the doctor must be knowledgeable about what does hydroxyurea do, how do you monitor, what is the benefit of having hydroxyurea as part of the treatment of sickle cell, why is it being prescribed, why do you have to adhere to medication? All those things are information that can be passed to the patient through the primary care doctor. Again, folic acid supplementation. Why is it important? Why is it needed? Some people have low hemoglobin and they want to go and use iron. Education around iron overload is important. And again, you have to monitor that through blood tests and all those things so that the patient know that, okay, I just don't take medication. I won't take iron supplement over the counter because my hemoglobin is low, because you may be having iron overload, and that can be very, very dangerous. And so all these are education that the patient can be offered at the primary care level. And again, sickle cell disease does not mean that you have sickle cell disease, does not mean that you cannot have other conditions, chronic conditions, asthma, hypertension, diabetes, mental health, anything can be associated with this condition. So adequate management, again, of all these complications are things that can be done at the primary care level. Most of the time, the crux of the matter, most of the patients come to doctors because of the pain, vaso-occlusive crisis. Patients have pain from occlusion of the vital organs in the body, especially the bones and even sometimes in the eye, in the chest, all those areas. How do you support patients in the care, in the pain management, even at home? Like we said, do they have access to medications all the time? They don't have to see the doctor every time for the pain medication. There should be adequate provision of pain medication. You start with the list, NSAID, acetaminophen, and then you can graduate to the one that is at least up to the time that the patient is comfortable with pain management. So these patients need to have access to all these medications at home. so that they take this medication before they even see their doctor if there is a crisis. And again, in the outpatient, what is the plan for the patient? How do you manage your pain when you're at home? When when it escalates and it's not manageable, what do you do? All these are plans that should be discussed with the patient. Usually, it's an individualized plan that the primary care doctor will have with this patient with sickle cell, including the family, so that they know, oh, these are the steps to take when this patient has crisis. Take the pain medication at home. If it's not getting better, see your family doctor. If it's not getting better, emergency room, and just so on and so forth. So you just don't go from not taking any medication to go to emergency room. No. Information has to be passed to the patient so that they know the systematic way of approaching this. And again, patients have side effects. You are taking medication most of the time, often, and it may develop side effects. So patients need to know to their primary care doctor what are the side effects of the medication I'm taking. Most of the patients that take NSAID, they have gastritis, have epigastric pain. They continue to have pain, and sometimes they can have ulcers. How do you help this patient? What medication can you add to support so that they don't have that or to prevent this from happening? These are all the things that can be discussed at the primary care level. And again, between crises, how do you support the patient? Financial loss, social impact, all these things can be discussed at the primary care level and the appropriate resources given to the patient. We have been discussing the physical all along, pain and kidney and eyes and stuff like that. Patients actually have a lot of psychological issues consequent of the fact that they have sickle cell. One, they cannot sometimes, if they're young kids, they don't understand, why am I different? Why are people not playing with me? Why can I not play like the rest of my colleagues? All these things are questions that people with sickle cell have in their mind. Sometimes silent fear. They feel discriminated against. They feel like, they cannot do what other children are doing. People, they frequent hospital and things like that. And all these things lead to depression, anxiety. A lot of school days are missed, and interaction with family members are all taking family resources on one person, making it unequal, or the resentment within the family. All these things are very common in sickle cell. So when you see a patient with sickle cell, you are treating the whole family because it's going to impact that family. So how do you support that family? Is the responsibility of the primary care doctor or the MRP to make sure that all these aspects of care are looked into. You talk to the family, you talk to the patient, you refer appropriately to the social networks that are available to help. Social worker will be there, health educationist will be there, navigator will be there, and resources in the community where the help can be sought. All these are the things that should be the responsibility of the primary care doctor. Because sometimes patients are so much engrossed with pain, they don't think of all this. But if somebody is there to coordinate, to make sure that they have access to all this, then it makes the care more holistic and more relevant. Now, patients, they don't know what is the origin of this. We know that sickle cell disease, people could have trait, people could have sickle cell disease. What is the difference? Why is it important? People these days, especially in African communities and Caribbean communities, partner testing is becoming common. Churches are actually advocating for this, and it's a good thing because patients, partners, before they get married, need to know their hemoglobin status, call it genotype. They need to know because it is when they know that they'll be able to make informed decision about that relationship. When somebody that has sickle cell trait is getting married to another person that has sickle cell trait, then they should be able to know that, you know what, you have a chance of having a patient that has sickle cell, and that's 25% chance. So they must be able to know and make up their mind about what to do moving forward. And this is something that can be arranged at the primary care level. So when you are seeing a patient, he has sickle cell, the family, the parents, everybody should be tested so that they know what is that, and inform the siblings that, you know what, when it's your turn to get married, these are the things you need to know, because it's very real that sickle cell is a disease that involves the whole family, and everybody needs to be understanding of that. Inheritance education. When do you know that, okay, this is something, like I said, is it hereditary? Am I going to inherit from my family or from my mother's side or something like that? What do I do with that? When you are going to get married, like fertility clinic, what are you going to, how are you going to navigate that process if you have sickle cell disease? Because you need specialized care. All these things are things that can be coordinated at the primary care level. And
Dr. Jusafe, we have about 4 minutes before we
lastly,
need to transition to Dr. Eric.
yes,
Is this your last slide? Okay, perfect.
yes, yeah, yeah, care coordination across specialties. So you can see that the sickle cell disease goes across so many specialties. Patients need to understand all the specialties are involved in the care. Hematologists will have to know about the patient, the prescribed the hydroxyurea, the monitor, like Dr. Pendergrass has said. The orthopedics will have to know about the patient if they have the avascular necrosis. Nephrology will know if there's a kidney complete problem. Mental health, the psychiatrist will have to know. So all these things are important. And lastly, when you transition a patient from pediatric to adult, who coordinates, who makes sure that the patient is not lost in transit? It's all the responsibility of the sure that the medications are, not missing, or they are refilled on time, and that the responsible doctor is taking care of the patient. So these are all the things that the patient needs to understand. And so a primary care specifically is essential in the management of sickle cell because it helps in the prevention, in the early detection of disease, chronic management of the disease, support for pain control, psychosocial care, and a smooth transition from pediatric to adulthood. Thank you.
Beautiful.
So that's what I have to say for now.
Perfect. We'll
Yeah.
have some time in Q&A for folks to ask any questions of you, Dr. Ajisafe. And thank you for that comprehensive overview of the different, interventions slash specialists slash opportunities for folks to really build a preventative kind of journey. To your point, prevention is an ounce of prevention is worth a pound of cure. So there's a number of things that are available for folks to take advantage of. So with last but certainly not least, we have Dr. Arak, like I made mention before. He's going to take some time to walk us through advancing optimal emergency care in sickle cell disease. Over to you, Dr. Arak.
Perfect, thank you. Let me just get
No
my
problem.
screen going.
Oh, perfect.
Make sure you can see the full screen.
Yes, indeed.
Perfect. So, thank you for this pleasure, the honor to speak on some work that we've done at my local shop. What's unique about this is, we're not, we're not a downtown university hospital. So this is a very portable and translatable case study for any sort of community hospital, big or small. It's a case study that shows how you can optimize sickle cell care from something as simple as awareness, which is where Sickle comes in. But then with awareness comes partnership, and then from partnership comes action. So thank you for the opportunity to speak. So I'm an ER physician, well, first of all, this is what we'll go through. We'll talk about the actual hospital where I work, the partnership with Sickle and how that sort of grew. And then I'll show you what we've done in terms of order sets, some data that we've kept and reporting that we've been doing, and a patient passport finally that we've put together, and then future initiatives of what we're planning to do. So this is what I want to say. So I work out of Humber River. I've been there for the last decade, and where we are, when you look at us, is we're right here in the middle of Toronto. What's unique about where we are as well is the population we serve. So We, as an ER, are a single site, and we get about 360 to 400 visits a day, which in perspective is quite busy, actually. We're one of two busiest single sites in Ontario in terms of ER visits. The population we serve also is sort of this part of Toronto here. It's about 850,000. I don't know if you can see my cursor, but it's about 850,000 individuals was our original catchment area in 2015. That's grown since. Our EMS volume is also large. So we're a busy place, and we're positioned in an area that traditionally has poor primary care attachment. The average in Ontario is about 23% primary care attachment. Our population tends to have somewhere closer to 12%. So that actually makes transition of care difficult where we are. So that's us. And these are some of the things that I mentioned. So we're a busy place, and our patients come from a diverse background and tend to not have as good primary care attachment. So how is this relevant to sickle cell? So we've been working over the last few years with a partnership through SCAGO, initially through outreach and then through medical education to actually build an increased resilience and knowledge within our staff to overcome barriers and biases, and then also to build a relationship so that projects can actually move at a faster pace. If you sort of look at it, a timeline, what we've done is, in 2021, it was still COVID. We were still grappling with that, but SCAGO reached out to us, and we actually first established contact with our first continuing medical education event. It was rounds that they spoke at, and they actually through SCAGO we got some resources that helped our initial approach to care. That same year, we participated in a virtual summit in the region with other community hospitals. So sickle cell started to be front of mind more so than it had been before since 2021. 2023, we started to work closer with SCAGO with the Sickle Cell Disease Education Program for healthcare professionals. And 2024 is really where everything took off. And part of that was thanks to the province itself, and the province actually put sickle cell as a quality standard. What we did is we started to work on a new order set. We had an order set before, but we optimized it. We also transitioned to a new EMR over the years before that, so we were able to optimize our order sets, and sickle cell was one of those order sets. And there was a focus on nursing education and physician training as well, in terms of approaching the things that we see in the ER. And the predominant thing we will see in ER when it comes to sickle cell will be vaso-occlusive crises. Sure, we need to worry about acute chest syndrome. Sure, we need to worry about sepsis, especially in the pediatric population. But by and far, the predominant thing we'll see will be, unfortunately, individuals who are in crises. And our goal has been and continues to be to identify those patients early and to provide them with analgesia as early as possible. We also established the sickle cell disease working group, which has been meeting regularly, and that all started in 2024. Last year, essentially, we were able to collect some data and monitor our performance in terms of time to analgesia, and also in terms of use of order set, and in terms of how well we're seeing patients. And finally, the end result is a patient passport whose main purpose was to help navigate the transitions of care. So from the ED setting or the inpatient setting to back out into community, and from community whenever they have to come back to the hospital. So I'll show you the order set in terms of what we did and how it looks like. But ultimately, our target was to get analgesia from the point of contact with our emergency department to under 30 minutes. The order set, the whole purpose of this was to streamline the physician workflow, and realistically it was to overcome barriers. The largest barrier that has been identified in the past, and that continues to be a barrier, is this concern about opioid overuse or misuse, and certainly there's concern about anti-black racism as well, in terms of giving opioids. So the whole point of the order set was to make an evidence-based one-stop shop for the ER doctors to use, and the use of the order sets was reinforced. So this is just briefly what it looks like. I mean, different order sets will look differently in different EMRs, but this is ours. And I just want to outline that as part of the order set, there's a protocol for the nursing staff that gets initiated. And this has them monitoring vitals, monitoring for fever, and escalating care as needed. The patients are there's also a protocol in terms of vital signs and CTAS scores, so that's how acute and how unwell the patient is, of moving the patient to either an ambulatory or monitored area. Not every single sickle cell vaso-occlusive crisis necessarily needs a monitor, and this is relevant especially in times of bed block, because our goal has been to obtain analgesia as soon as possible. We have all the regular things in terms of monitoring IV therapy, monitoring of respirations, the diagnostics and laboratory. But what I want to highlight here is really the management of pain. So opioid management is a hurdle, is an obstacle, but sometimes even in the extreme cases of pain, we can forget that there's multimodal ways of approaching analgesia. So the order set does guide the provider to still provide the Tylenol, still provide the anti-inflammatory medication where appropriate. But here's where the meat of the order sets have come in, and this is what has facilitated the physicians to actually order appropriate analgesia as needed. And we divided the patients as opioid naive and opioid tolerant, and there were multiple modalities and ways to actually give analgesia. Ultimately, we haven't gotten there, but at UHN in downtown Toronto, what they actually do is they give fentanyl in the waiting room, which is a much more potent and faster acting opioid. It's sort of, I wouldn't say it's outside of standard of care, but it is providing fentanyl outside of a monitor setting tends to make people hesitant, or make programs hesitant. But it has been demonstrated as a very effective and safe modality. So in terms of future direction, this is somewhere where our order set is hoping to go. When you see in opioid tolerant individuals, the starting doses are what you see there. Now, I will say, oftentimes, and what we've been teaching our physicians and our nurses, patients will come in, especially when they're opioid tolerant, with doses that are much higher than this. So that the teaching has been and continues to be to ask what dose has worked in the past, and to order that dose. So the goal of the order set here was to guide ordering and of opioids, regardless, and to minimize delay. It's not uncommon to have, in terms of milligrams, 4, 8, sometimes even 10 milligrams of hydromorphone per dose required. And then finally, I just want to demonstrate, again, the order set is completed with other adjuvant therapies, and we also, even though it's a vaso-occlusive order set, we came to the conclusion, based on other partners and other hospitals in the region, that acute chest syndrome is such an important differential diagnosis of vaso-occlusive crises that carries such a high morbidity and mortality that we did not want this missed. So this was actually included in our order set, and the physicians were guided to think the importance of this is the way we would treat pneumonia in an average population, or an equivalently aged individual without sickle cell would not necessarily be the same as what is required in terms of potency and types of antibiotics that are used. Specifically, vancomycin wouldn't commonly be used or regularly be used. So this again guides that treatment. And then what I want to show here, sure, we also have directions of involving social work and physician consult, but like I mentioned, our patients are not as attached to primary care. Our family medicine teaching unit, which opened around the same time as this work has been going on, actually a bit earlier, is still and has been actively recruiting patients. So part of our management of the patients in the acute care setting in the emerge has been to help facilitate attachment of these patients to primary care and to family doctors. So this referrals to the family medicine teaching unit and the order set helps guide that. Now, the order set as part of the initiative locally and provincially has been tracked, and this evidence to practice reporting is what we've done. So I've taken this from our own data and our own presentation. We sort of kicked off the implementation of the order sets and the monitoring in October 2024 in terms of actually getting everything together, and it went live March 2025. The data I will show you will actually look at we'll compare a pre and post, with really the post is up to 5 months from starting from that March 2025. And here you actually see the average time patients with sickle cell are waiting has gone down, and had gone down dramatically. And this again was part of the initiative to identify those patients and to bring them to the attention of a physician as soon as possible. We've also been successful in, this is opioid. This is what I meant in terms of physician initial assessment. This was the opioid, time to opioid. So like you see in minutes, we've been as high as, 224 minutes, and we've reduced that to about an hour. Our target still remains 30 minutes. But we've dramatically reduced the amount of time patients have been waiting for opioid analgesia. And this, like I mentioned, is time to the initial assessment by the physician for the patients. So where all that has accumulated now, where we've sort of come to is designing a passport for the patient. This is what ours looks like, and part of, like I mentioned, our standard of care is to ask patients what they use for pain and what dose they require. Oftentimes patients know, but then equally as often patients don't know. And the purpose of this passport is to facilitate that. In addition to that, the knowledge and comfort of ER physicians with hydroxyurea or asking about hydroxyurea is varied. So, and on top of not just hydroxyurea, but folic acid, other medications, preventative antibiotics. This passport is supposed to highlight the fact that patients may be taking these, should be taking these, and to continue to start the discussion. As a result of this work, often the discharge discussion is, hey, are you on hydroxyurea? No. Do you have a primary care provider? Is there somebody who you can talk to about getting this prescribed, for example? For sure, there are reasons why to seek emergency medicine care, and the whole point of this is for the partner, for this to be a partnership and collaborative with the patient. So patients are advised what their rights are and how they can make decisions, and if they can decline and stop treatment at any time. So that's where we are now. In the future, where do we see ourselves going? Where do we hope to go? Well, one thing we're in the process of doing now is trying to use an inhaled anesthetic that has been used quite a lot in pre-hospital care, especially in Australia and New Zealand. It is used acutely for MSK or orthopedic care in the emergency room as well. It's an inhaled anesthetic that is generally safe. We're hoping, we're still in the approval phase, hoping to actually test this in the waiting room or in the pre-treatment stage for our patients. So that's something exciting on the horizon. Now, there's ongoing professional development. There's ongoing reassessment of order sets. Physicians actually do get an automated email that states, hey, you saw a patient with sickle cell on such date. You didn't use the order set. Just a reminder it exists. The order set will constantly be optimized. We're always looking for other educational opportunities. And realistically, transition of care is probably the biggest challenge. In an ideal world, there would be an opportunity to attach every patient who comes to the emergency room or gets admitted to the hospital to a sickle cell, home, medical home, and for patients who aren't on hydroxyurea to actually initiate that in a hospital and transition them out. We're not there yet, unfortunately, but that is the ideal, that is the hope and the goal. So I think that's my summary. I'm open for more questions. I'm happy to I'm going to stop sharing here. I'm happy to answer any further questions. Yeah.
Beautiful. Thank you to each of our three speakers. This has been fantastic. Um, Dr. Eric, I hope you don't mind. I shared the Humber River Passport to Care in the chat just so folks can kind of get access to it. Tangible tools, well, it's digital, but when you download it and print it off, it'll be a tangible tool. I think are great for folks to kind of walk with, especially when going into interactions in the hospital setting. That's fantastic, and happy to see the work coming out of Humber River. We do have two questions. The first of which I think is probably directed to all three of you, truth be told. But Dr. Pendergrass, maybe I can start with you since you're the person who spoke the earliest. What are the most common system barriers to integrated care for people with sickle cell disease, and how can families work around them?
I think the major barrier, I mean, there's many barriers, but to my mind, the number one barrier is an absence of physicians with a committed interest to patients with this diagnosis, particularly
Great.
adults. It's very hard to do anything else without that there first. I mean, it's not just for the provision of care, but also just to advocate, just to collaborate and get those networks formed with other physicians. I think that's really where we need to focus our efforts is just to get more people to go into the field. There are solutions to that. I think, unfortunately for many physicians, their only encounter with sickle cell disease during their training is patients who are admitted to hospital with a pain crisis.
Right.
And the patients who are admitted to pain crisis that they are going to see most often are the patients who have extremely poorly controlled disease, who have chronic pain, who have significant social issues that they have to deal with, and they don't see anything else. That's their understanding of what sickle cell disease is. And for sure, that is part of it. That population is there, and they do need to be cared for. But when they come to my outpatient clinic, without fail, they're always amazed at how varied the care is. How the deep connections that you can form with a patient, when they're not in agony, like when they're not in pain, and you're able to have a conversation and talk about their journey and celebrate their victories. When they come into clinic with a newborn baby, I mean, like it is so wonderful. um and uh um and I think it opens people's eyes to say, I could do this for a living and I could enjoy this for a living. And in particular, there's so many exciting developments coming down the pipeline, new therapies, gene therapy. So I think just getting more people to sort of see sickle cell patients in the full entirety of their care, not just during an acute pain crisis, but in between as well. That will help get people more into the field. That will create more capacity to see patients, and that will help build those comprehensive care centers. That's my feeling about it.
That's fantastic. And that's where I think the schedule can play a role in terms of advocating for more rotations, going through places like your outpatient clinic to get exposed.
Mhm.
Dr. Ajisafi, would you like to also submit any thoughts around that question in and around common system barriers to integrated care for people living with sickle cell disease?
Yes. As previously mentioned, there is a pure gap in knowledge of the family care physicians in the care of sickle cell patients. One, they are not, the training is not that robust because it's not a Caucasian disease. It's more of African Caribbean. So unless you have that training or you have access to number of patients that have the disease, there's no way you can get the training. So that is why only specialized care in this country is know more about the disease, but the average family physician does not. And that is part of the problem. Again, even when you even go to the emergency room, most of the emergency room doctors, because of the crisis, most of them too are family doctors. They don't know much about this disease. So it's the same thing. So you go from there, now they just teach you medication. You don't. That's all they send you back to somebody that doesn't know much. So that's why the body is much on the hematologist because they have to go to the clinic every time. So if knowledge is disseminated and more people are aware, more of the doctors are trained in this area, and like you make it like a field. Like I don't see many hospital or comprehensive health care having sickle cell clinics. If they have a dedicated sickle cell clinic, then they will know that the patient that is there has the knowledge, has the training in the care of this patient. So it will make the care more robust and more focused. And again, the patient will get the benefit of all the care that they are supposed to have in the management of their condition.
Well said, Dr. Ajisafe. I mean, quite literally, not all diseases were created equal. And so are we seeing the level of interest in different diseases. So perhaps there's a way to kind of build that interest to your point. Dr. Eric, anything you want to add?
But no, I agree with both colleagues. I mean, I think Dr. Ajisafi is a rare primary care physician in terms of knowledge and the type of practice he has. Sometimes also, unfortunately, we're sort of cursed by the name itself. You know, sickle cell anemia sounds so benign in terms of what it is as an actual disease. It's a hemoglobinopathy, but I think, you know, in training and in the individuals that treat it, it's sort of, you know, it rings just like iron deficiency anemia. It sort of categorized the same way in your vision, but realistically, it's a much more complicated disease, and it's not just simply the blood sickles. There's all these cascades that happen, and you know the risk. And I think if you were to straw poll the average ER physician or the average primary care physician in terms of life expectancy and morbidity and mortality that was shared by Dr. Pendergrass, I don't think any of us would you know, without who aren't involved, would actually be anywhere close to saying that the life expectancy is that low, right? So it's an unfortunate paucity of comprehensive continuity of care. Yeah, so I agree with them.
Thank you for that, Dr. Eric. There's one element of the question, actually, Dr. Pendergrass, I want to come back to you and Dr. Ajisafe in and around how families can work around these barriers. You know, it's a wicked problem. There's no one particular solution, but I don't know if you have any advice you could maybe provide to the audience in that respect.
I think, you know, there's an initiative underway to create a provincial model of care, that you know it clarifies, what the responsibility of various hospitals is, to the patient population in their catchment area. And, I think this will do a great deal to clear up some misperceptions or disagreements that some hospitals have that this is not their problem, and I think, that is too often, we hear this from hospitals that say like, oh, we don't treat sickle cell disease here. You need to go to the Toronto General,
Right.
or, you need to go to Sick Kids. We don't do
We
that
don't do
here.
that.
And the
Yeah.
provincial model of care will say, actually, you do have to provide some care. You don't necessarily have to provide gene therapy.
Right.
You don't have to like,
Right. Blood
but
transfusion.
these patients are in your community, and
Hmm.
you need to resource appropriately to care for them. That doesn't mean
Hmm.
absolutely tertiary level, academic level clinical trials,
Right.
but that does mean you have
Right.
to do something. And I think if the patients and their families come to the hospital with that document, which is not finalized yet, but when it is finalized, and say, look, you're named in this document as a place that has to provide care. What are you doing? What are you doing
Right.
to, I think that's a way that you can advocate. And
100%.
every hospital has a patient relations department, that is there for that purpose to come in, and deal with concerns from the community. So that's probably the best way to advocate, I would say.
That's just it. You have agency, folks, and leverage the resources in place to make sure your voices are heard. So, to your point, we'll be sure to circulate that document when it becomes available. Dr. Ajisafe, is there anything you want to provide to in terms of workarounds for family members?
Yeah, I think family members, it's like they're part of the issues that face the sickle cell patient face, because knowledge is very important. They need to be incorporated into the care. And it is only when they understand the concept that they can see how to navigate the system and how to seek help. Because sometimes, we are dealing with kids sometimes, most of the time, sickle cell patients, they are children. So they need somebody that is knowledgeable in how to treat this disease to help them. So it's very important that anytime we are talking about sickle cell disease, we need to incorporate this with the family as well, because the family actually that it depends on how knowledgeable the family is that the care will be optimal. So I agree that patients need care, but the family needs education. They need support. They need all the resources available to help manage this care. So it's a holistic thing, and patients need to. And the government is doing something right now because of the quality control. They are involving the family now. They are looking at the other aspect of care. And it is when we integrate all this together that we can have a quality, comprehensive care for this patient, not just focusing on the sickle cell disease patient alone.
Beautiful. Just to remind folks, Dr. Pendergrass, you referred to it as a comprehensive model of care for sickle cell disease. You're saying that is to be released in the coming, well, in the near future. Okay.
It's a provincial model for care. I think
Thank you.
the
Provincial model for care.
the guidelines for how to treat sickle cell disease are out there. I mean, there's no shortage of literature about how to properly treat sickle cell disease, and there are other guidelines as well about what sort of resources should be available to a patient, whether that's all in one place or in a distributed model. But what the document that's coming out basically categorizes the hospitals in Ontario to say, you are a, sort of more of a primary site, you are sort of a regional referral site, and you are a tertiary level specialized care site, and just make it very clear because I think it's very easy, for a hospital to say like, oh, we couldn't possibly provide care for sickle cell patients because we don't do apheresis, red cell exchanges. And this document says that's not what you're being asked to
No,
do. You're being
right.
asked to, provide, vaccinations, annual eye exams, echocardiograms every few years, not expensive stuff, So I think that's going to be a very helpful document to have.
Beautiful. Dr. Arax, I know you're on mute, but I want to pull you back to the front stage. This is a more particular, given you are, working in emergency kind of settings. How can patients advocate for themselves in emergency settings where staff may not know their history?
It's difficult because patients come to the emergency room in crises, and you're never
Yeah.
your best self in a crisis. And then it's an unfortunate burden that we expect for patients and families that when you're in a crisis and not at your best, that you need to sort of put on this act and be nice and try and explain, and it is difficult. So if you take a step back, one of the best things you can do to advocate for yourself is, this is where a patient passport comes in, for example, but even on your
Right.
own is just to know your own history, or have a living document that you can bring with you, or a family member can bring with you, that says, this is how many times we've been admitted, this is what's worked, this is what I take at home. From my perspective, even at the very least, if you just have what medications you take at home with you, very easily accessible, and what medications work in crises, that often helps. The biggest barrier that we're still trying to overcome is just the dose of opioids that people may need for crises. And there's also a barrier of going from oral to IV. And oftentimes the team may not know. Listen, I have a good plan at home. For example, I've done the Tylenol, I've done the Advil, I've even done the morphine orally. It just doesn't work. I'm here because I'm in crises. I need this dose IV, for example. And if you just ask, and if you have that often helps. It's it's a difficult thing because ERs are also in strain. So while it is at the forefront right now, and we do try to pull people to the front of the line as much as possible, depending on the time of day and depending on what hospital you show up to, it may be different. So, but I still don't think the answer is understand that everything's busy. No, you still need to advocate. But I think having all your own information ready with you, just like this document will make it difficult for hospitals to sort of say we don't treat this. I think having a document that says this is what my care plan is, it makes it more difficult for your care team to say, well, we're not comfortable doing that. So that would
Exactly.
be my advice.
Beautiful. Folks, as you can imagine, we burned through our 90 minutes in no small order. And I definitely want to appreciate and respect everyone's Saturdays. So to that effect, I don't see any more questions in the Q&A. Of course, if you do have any more questions for our speakers, you can you can definitely email me and I'll make sure to try and direct them to folks. I'm just going to put my email in the chat in the interim if there's any more questions that we weren't able to get to. But with that, I just want to send a big thank you to our three speakers, Dr. Jacob Pendergrass, Dr. Ola Jasafin, Dr. Marco Arak. Thank you so much for taking time out of your busy schedules to be with us this morning. We appreciate your work, and most importantly, we appreciate the support you have for members of our community. Oh, go ahead, Dr. Pendergrass. I don't know if it's a high five or is that a hand up? Oh, clap. Perfect. Perfect. No, round of applause for you folks. It's been a fantastic session. To all members of those online, as mentioned, this session is recorded. If you want to refer to it at your own leisure, it'll be posted shortly to our education space on our sicklecellanemia.ca website. And with that, wishing you all a great Saturday, great rest of weekend, and hoping you had a great time in today's session. Thank you, folks, once again. Take care.
Thank you.
Thank you. Bye-bye.
Yeah.
Bye-bye now.
Bye.